I'm going to introduce our speakers tonight, and I have to have a paper because their titles are very long, and I couldn't possibly memorize them. But we have a great panel for you tonight to talk about what's going on in the greater Boston area, across the state, as a matter of fact, in issues in suicide prevention and how it affects us as social workers today. So we're going to have our panelists speaking for the first part, and then we'll open it up to question and answer. So we hope you've all come armed with lots of questions and curiosities about how we can move forward in this really interesting topic area. So I'm just going to introduce the three first. I'll start with Betty Ruth, who's the first person here to my left. Betty is a BU School of Social Work graduate in 1984, and she is currently the clinical associate professor in the school, director of the MSW MPH program, director of the certificate program in clinical social work and behavior medicine, and director of professional education programs, and is currently the principal investigator on the suicide prevention and social work grant through the School of Social Work. So you see why I had to read her title. Next to her is Heather Whiteman, who is a BU School of Social Work graduate in 1997. And Heather is currently the project coordinator of the Garrett Lee Smith Memorial Youth Suicide Prevention Project at the Division of Injury and Violence Prevention at the Mass Department of Public Health. And finally, to the left of Heather is Jim McCauley, who graduated from BU in 1976, Director of Youth and Family Services at Riverside Community Care. So we'll welcome our panelists here tonight. And we'll start with Betty.
Hi, everybody. I know some of you, and I want to welcome all of you. I'm really indebted to Heather, so I just want to acknowledge that from the very beginning, because the inception of this project was probably summer of 2006 when she came to my office and said, you know, we're going to have some money to do some interesting things, and we'd really like to figure out a way to include schools of social work in it. And there are a lot of times when people come to your office and they have ideas and they want you to talk about them, and you do, and then nothing happens with them. But this is one of those really wonderful situations where Heather really put together a very creative package of an RFP where we had to bid to do an assessment to determine how much suicide education was going on in our School of Social Work and in our BU School of Social Work community, and then later broke open another line of funding to actually implement some of the ideas that we developed. So I just want to tell you a little bit about what happened. I don't know when you were all students here, but when I was a student here, we didn't get any suicide education, or really we didn't get very much suicide education. To the extent that we got any at all, it occurred in our field placements, and that was catch as catch can. Some field placements offered a bit, others did not. So when we set about to assess what we were doing at the School of Social Work, I have to admit I went in with a bias. My bias was that I didn't think, after being on the faculty for more than a decade, that we were doing very much with it. And I want to tell you just a 5 minutes worth of what we did find. We reviewed our curriculum. We looked at all of our syllabi from 2004 to 2006. There was one article, and it didn't actually hit the syllabi until 2006 on the issue of suicide. We did a critical review of the literature within social work, and we only looked at 5 journals because we didn't have time to look at all of them, but we looked at them from 2004 to 2006, and we found that there were no articles, 0 articles in 4 out of the 5 journals. There was 1 article in social work, and in that article, the main thrust was what to do after your clients had taken their lives by suicide, not how to stop them or intervene in that process. So we were pretty concerned about that. We also assessed our students. We did a survey with all second-year students last year. About 82% of our students said they got 4 or fewer hours of suicide prevention or intervention training in the course of the MSW program. About a quarter of our own students, and I don't think I'm being mean to our school. I know I'm not being mean to our school, and I'll tell you why in a minute. A quarter of our students did not get any training at all in suicide prevention. That's 1/4 of all the MSW graduates coming out of here and never heard the word suicide, okay? And what to do about it. Now, when you consider that more than 30,000 people die by suicide each year in this country, and when you consider that over 650,000 people are brought to emergency rooms and that for suicide attempts, and that this is probably likely an undercount because of reporting difficulties and coding difficulties. This is a very big public health issue. We looked at our faculty, and it was very interesting talking to faculty. First of all, they said, oh, yeah, we admitted up front, we're not doing this. Okay, and so then we pressed a little more and said, so what's going on with this? And people talked about the curriculum was too jam-packed, the expectation that students were being trained in the field, and the lack of knowledge and lack of consensus about their own lack of knowledge and lack of consensus about what social workers should know. Because it's not exactly the same as what psychologists should know or what psychiatrists should know. Social workers, we all know this, work in unique ways in particular settings in very different roles than other allied mental health professions. Finally, we surveyed our field supervisors, and 95% of them said they possessed some skills in suicide prevention or intervention, but most of them also acknowledged that they had not been trained formally for more than a couple hours themselves. We did one alumni group that we brought alumni together, and we asked them, we actually brought MSW and PH alumni together because we figured out of all the alumni, this would be a group that would be tuned into suicide, and we wanted to see if we could get at what the issues were with training. And folks talked a lot about the lack of leadership in the social work profession writ large on this issue. They talked about lack of comfort with public health tools and lack of research by social workers in general. Finally, we looked across the BU system and said, what's going on? And there was not one course on suicide offered in BU. We have 20-something schools of professional schools. There's not one, okay? A medical school, school of public health, psychology, rehab counseling. I mean, I can go on and on. You know what those schools are, not one. We lacked journals. We lacked books. We lacked videos. We did not have an institute. There were no focal research groups. There were no working groups. So we had our work cut out for us when we went in for this grant on implementation to do something about it. But this is the cool part. This is what we're doing, okay? In order to address this, we developed some really fun projects. I'll just very briefly mention to you what they are. Faculty development fellowships. First of all, you can't get students trained unless you train faculty, because faculty need to own the knowledge first and really develop it in themselves. 5 of our faculty, but another 4 are involved in various administrative roles. But 5 faculty fellows are developing resource kits. They're looking at their departments. They come from all different departments. It's a rare opportunity for faculty from all departments to work together, so it's very fun. They're going out to conferences. They're developing case vignettes. They're looking at areas to plug this stuff into the curriculum. Student agency collaborative fellowships was another piece of our project. 5 teams of students and supervisors are receiving, by the way, the faculties are receiving more than 40 hours of training. The field supervisors and students are being offered roughly between 25 and 30 hours of training. And the students are conducting needs assessments and plans for integration of resources into their agencies. So that's also very fun. And we picked a diverse array of agencies that represented high-risk populations. We house within professional education a number of training institutes. A number of you will be hearing about this if you're field supervisors. We're about to launch a field supervisor series, faculty advisor series, and an alumni series where we're doing 5 workshops, bringing in really talented people to work with us on a variety of aspects of suicide prevention and intervention, not just intervention, but thinking from a community-wide lens as well. And in fact, one of Jim's colleagues, Larry Berkowitz, is going to be doing a piece on community responses to trauma, including suicide. There is a student project that we're just launching in honor of Public Health Week. This is all about getting the voices of students involved, and this is a total creativity project for students. We're giving them a gift card. They're coming in. They're going to do, we hope, some art, some reflections, some personal thinking, some poetry, some fictionalized expressions from their case experiences of why they need to know suicide prevention and intervention and why it has to be built into curricula. Students are going to also be offered QPR training, which is gatekeeper training. We're actually hoping to build that into orientation and have that be part of our sustainability plan. And 5 students are being sent on scholarship in addition to the 5 fellows to the conference, the Mass DPH DMH Joint Conference in May. Couple of other things. When I said I would do this project, and Heather knows this about me, I only agreed to do it if we could do basic scientific research with it. I feel very strongly that the area around suicide has not been mapped in any way for the profession of social work. We're really underrepresented in the scientific literature. There are 2 pieces of research that are going on that are linked to this project that we are doing. One is a survey of deans and directors. This is ongoing, online, right in the moment. These are deans and directors of all schools of social work, because as you can imagine, we kind of looked around ourselves at BU and thought, are we the worst? Like, are we the really, like, outliers? Are we the bad guys not doing this? And in fact, actually, we're really fine compared to the rest of the schools that so far have answered our survey, which is not reassuring. But in fact, fewer than 4 hours of training is being provided, as far as we can tell, to the majority of schools of social work. And in fact, there isn't a lot of interest in changing this. Most deans that we have heard from so far, and we've got about a 22-23% response rate at this moment, are saying, yeah, you know, we just can't fit this in. So sorry, but we don't have room for it, or we have other priorities. 30,000 lives lost and 650,000 people going into hospitals is a big issue to have other priorities about, you know? So we're hoping to make the case that to change this. And finally, we intend to do and are about to launch a faculty focus group project. In part, we're aware of the need for a deeper conversation than a survey can give us among faculty, and we don't want the conversation just to be limited to BU. In fact, the state has funded several, Heather's going to tell you, several other schools of social work. What our intention is to bring the faculty from all the schools of social work together into a qualitative inquiry, which we're going to be doing over May and June, asking if we can get some ideas about how to break through some of the obstacles, understand the challenges better of integrating suicide prevention intervention into MSW curricula, plural, sorry. So that's what we're up to, and I don't want to take too much time so I can give my colleagues some time. Thank you.
Hello. So I'm Heather Whiteman. I graduated, I think most of you are probably a combination of people that are currently in the School of Social Work completing your degrees and then others that have graduated some years ago. Is that true? I get that for everybody. Are any of you currently either, let's see, dual degree graduates or current students? Dual degree graduates, let's see. Current student, public health and social work. A couple of you? Okay. Well, so that's how Betty and I became such good friends, because she's such a fabulous leader and incredible mentor. But I was a dual degree social work and public health student. I was a macro social work graduate and a social and behavioral sciences public health graduate. And this was way back quite some time ago, and I can't even believe that, but now 10 years ago, which is insane. But anyways, I was brought to the Department of Public Health only 2 years ago. So I did a number of other things before ending up at the Department of Public Health. But I was brought to the department to administer a federal grant, a SAMHSA grant that was called the Garrett Lee Smith Appropriation. I don't know if some of you may be familiar with it. It's a youth suicide prevention allocation. It was about a $40 million allocation appropriation that happened, let's see, 2005, and the Department of Public Health here in Massachusetts was one of 13 states that was actually the first 13 states to be awarded, to be funded, to be able to do this teen suicide prevention work. Having said that, our first year was focused on 3 different pieces. One was to work with the Department of Social Services, again, around teen suicide prevention. The other piece was to work with the Department of Youth Services around teen suicide prevention. And the fourth piece was to work with the schools of social work here in the state. There are 8 of them, graduate schools of social work, that offer MSW degrees. And from those 8, so for that piece of the project, we actually were able to fund, needs assessments, essentially, that BU that Betty was describing to you in great detail. But of the 8 schools, we actually received 5 applications. We were able to fund those 5 needs assessments, which was with Boston University, which was also with Simmons, Salem, Springfield, and Bridgewater State. So those were the 5 schools that we were able to focus on. From that needs assessment, which was a year, $10,000, very small appropriation that was spread across a year's fiscal year for the state, they then worked towards implementation plans, and that's where Betty was feeding lots of more detail. Right now, we have 4 of those schools that are in the middle of their implementation plans, much larger allocations, and in the case of BU, it's actually almost a $100,000 allocation that is going towards doing some really fine, interesting work. I'm not sure if we'll be able to fund any of those schools beyond this second year, but we sure are hoping to, and we're really excited to be able to learn some of the more finer details that Betty is speaking to, working with faculty and, of course, across nationally, working with deans or being able to pick the brains a little bit of the deans of schools of social work across the country. But having said that, the Department of Public Health suicide prevention program here in Massachusetts is an incredible team to work on, but besides that, we have our fingers in so many different pieces. This is one very small piece of the work that comes through the Department of Public Health suicide prevention program. I'll give you a little bit of history of it, but I will also say, given that I'm here just for a short time, if anyone has any questions or wants finer detail, more detail, or perhaps be connected with the director of the suicide prevention program at the Department of Public Health, who is Alan Homeland, I can certainly do that if you just leave me your name, number, your card, and I can get back to you easily over the coming weeks and get you whatever it is that you need. Having said that, the suicide prevention program is a very young initiative. The Department of Public Health had no money to put towards suicide prevention until 2002. And that was actually only made possible because of a team of people that were outside of the Department of Public Health that came together and put together a strategic plan for the state. It actually models the National Suicide Prevention Strategic Plan, and to this day is actually still the plan that is used. And currently, that's one piece of where the monies are going that the Department of Public Health has. Suicide prevention program is going towards trying to update, renovate the strategic plan so it more speaks to the needs of the residents of the state, citizens of the states today regarding suicide prevention. But having said that, in 2002, there was a very small appropriation of $500,000 that was allocated to the Department of Public Health under a line item suicide prevention program, and that $500,000 actually has now grown to $3.75 million, which was this fiscal year 2007 appropriation. So it has grown substantially, and hence the work of the team has grown substantially as well. Some of the things that come through the Department of Public Health suicide prevention program: surveillance, naturally, some numbers that I can spin out to you that are not as I would say updated as we'd like them to be, which is purely just part of the bureaucracy. If any of you work with as a statistician or work at all in evaluation and epidemiology, you'll be very comfortable with this piece. But in 2005, we have 469 Massachusetts residents died by suicide. This is the comparative that the state likes to use, and it seems formidable. I mean, there are lots of other comparatives, but there were about 178 homicides in that same year, which is a 2.5 difference. So there are 2.5 more, unfortunately, suicides in the state than there are homicides. And I don't need to tell any of us what you typically read about in newspapers or see on your local news broadcasts are definitely more so homicides and suicides. In fact, even to this day, speaking the word suicide or asking someone if they're suicidal is very much an uncomfortable situation that I don't think any of us like to be in. And that's part of what the department is really trying to work towards, is that stigma, trying to remove the stigma so that you're able to get closer to being able to serve whether that's your family, your friends, or even the clients that you might be working with at any other point in time. In 2005, which Betty spoke to some of this nationally, there were almost 4,000 hospital stays for self-inflicted injuries. A self-inflicted injury is just as it stated, it's an injury that you give to yourself. Could be as minor as a scratch on your arm, could be as serious as a fatal wound of some type. In 2005 as well, there were almost 7,000 emergency department visits for self-inflicted injuries. Those are two different sets: hospital stays, which is staying within 20, you actually are given a bed, so it's a hospital stay versus an emergency room visit. And again, these, as Betty has said, these are defined pieces of information. There are certainly lots of hospital stays and lots of emergency room visits that come in undefined. There are certainly lots of deaths in the state. There's a whole category of surveillance that is undetermined death, and many of those end up being drug overdoses and therefore undetermined death as far as was it a suicide, was it not a suicide, was it an accident, was it even possibly a homicide for that matter. The highest rate of suicide here in the state, again, this is reflecting back on 2005, but this still stands true as we know it with preliminary data that's come out for 2006. The highest rate of suicide is among men that are over 85 years old. The highest number of suicides is actually middle-aged men, so you understand the difference. And I think something that I know my director likes to sort of present, and it's certainly startling, is on average 53 individuals will attempt suicide in the state of Massachusetts every 5 days. 53 individuals will attempt suicide in the state every 5 days. Having said that, what do we do besides fund Betty and the other schools of social work that we fund? We do lots, which Riverside, as you're going to learn more about, is a large contract that the Department of Public Health Suicide Prevention Program actually supports, which is actually the details I'll let Jim give you, but it is one of our probably stronger funding, or I would say stronger contracts that we manage. It has a history, that is pretty solid, and Larry Berkowitz is part of that, and you'll learn more about that, as I'll say. But other things we do is surveillance, clearly, through the Department of Public Health Suicide Prevention Program. There's conferences, and the list of them can be pretty deep, but I would say the most well-known conference is the annual Suicide Prevention Conference that happens typically in May. It did happen in late April a couple of years ago, but May, once again, is the 13th and 14th of May for this year. Other sorts of things are training. I know that the Department of Public Health is always looking and will continue to look hard for evidence-based programming, evidence-based training towards preventing suicide. There, as Betty has said, there's very little, I would say probably next to none. There are certainly some initiatives. The SOS program, perhaps some of you may know, it's a tool that's used with middle and high school students, a suicide prevention tool. Has its limits, I would say, but there has been some research, some monies that have gone into evaluating its effectiveness, but that again is very, very limited. And certainly there wasn't any sort of broad-based or national study done or anything like that, or even a lot of dollars put towards that. I know they're continuing to try to change that. QPR, which is another training that Betty had mentioned, which is question, persuade, refer. It's a suicide prevention gatekeeper training. Gatekeeper, for those of you who may not know this, is a term used for just anyone who has a relationship with someone who may be at risk of suicide. Therefore, a gatekeeper. It could be a parent. It could be a guidance counselor. It could be, it could be a physician. It could be anyone, but a gatekeeper, a caregiver, provider of some sort. But so gatekeeper trainings, this QPR training, is something that I know the Department of Public Health Suicide Prevention Program uses pretty extensively. It is, I would say, probably one of the easiest trainings, gatekeeper trainings, to deliver, to one teach, and then further to be able to deliver it to others. It's something where you can, kind of put suicide prevention 101 in your back pocket and then be able to distribute it widely, be able to give people just a little bit, which could actually save someone's life. So it's that sort of a training, but certainly is not evidence-based. There are other trainings that we espouse to that that help people to understand better how to prevent a suicide, how to talk about it, but we're always looking for better modes to be able to really affect people's lives. I would say approaching suicide prevention from this public health community development perspective would be really ideal, but we're not yet there. And I would say for the Department of Public Health, we're still struggling with kind of how to conceptualize that. There is a statewide coalition, Massachusetts Coalition for Suicide Prevention, that is trying to, I would say, work towards a community development perspective. But even within that coalition, there are gaps in membership. Who shows up to the meeting very much dictates ultimately where the meeting goes and how the resources get invested. affected. So I would say those of you, if you're interested in this, there's just so much room to really be able to do a much better job, much more comprehensive, develop a much more comprehensive approach to really helping people who are struggling, psychologically really struggling in their lives. Other things that we do, suicide prevention service contracts, is a whole host of them, working with the GLBT community, is a bunch of Fenway Community Health phone line. There's a whole sector of work that we're doing, post-vention services. I don't know if folks are familiar with post-vention services, but when somebody dies by suicide, there's a whole set of protocol that happens working with their community, whether that's their family community or their workplace community, or it could be a school. But there's all these post-vention, very much after the incident has happened, all these services that can filter to any one particular community, any one particular group, that can really help to prevent, certainly, another suicide, another traumatic loss. So that's a whole host of resources goes towards that piece. Recently, we have a Department of Veterans Services contract that's a very large appropriation coming out of the suicide prevention program, and it's obviously to work towards preventing a whole host of things, but naturally suicide in relationship to veterans that are currently returning, or veterans that have returned in the past, or veterans that are actively serving that need services, or if their families need services. Other work, strategic planning process that is very much done in collaboration with this coalition, statewide coalition, Massachusetts Coalition for Suicide Prevention. That's a huge undertaking that the department is in the midst of, towards really trying to renovate the strategic plan that we're currently using. So making the next generation strategic plan, working with youth and young adult suicide prevention programs such as the SOS program and others. We collaborate with a whole host of different folks that include DMH and as well DOE, Department of Mental Health, Department of Education. There's survivor support groups is becoming a larger piece of the work that the department does. And when I say survivor support groups, these survivors within the field of suicide prevention are actually folks that have lost someone to suicide. It's not necessarily someone, although it could be, but it isn't necessarily somebody who has tried to take their lives and survived. And in that case, I guess the language in the field is very much an attempt survivor, but a survivor in general is anybody who has lost someone to suicide. It's a whole host of our money that goes into those support groups, and developing more across the state, because there are very few currently across the state. And then the Garrett Lee Smith appropriation, as I've already described to you. I think I've probably spoken too long. There's some poison control monies. There's lots of resource development and distribution that happens. I would say if any of you are looking for resources for your field, for your work, for your family, for your community, the Department of Public Health Suicide Prevention Program is definitely a place to start with. It's certainly not the only place, but it's a place to start. And we're always, always, always interested to get more involved in the community. I know we're in the process of writing what would be the next generation of this Garrett Lee Smith monies. We have been given an opportunity to apply again for these Garrett Lee Smith monies, which we weren't sure about, but it ends up we are able to do that. And this is towards preventing teen suicide, so it still has that particular frame, but how the department is hoping to be able to try to get these monies. So our application, although we're hoping we're funded, you never know, we may not be funded, but our application is going to really work towards developing some sort of a communication mechanism, reporting mechanism, because currently when a suicide happens anywhere in the state, the Department of Public Health is usually the last group to know, which is really interesting, only because our only way of communication is by word of mouth, the newspaper, or the medical examiner's office, but typically that could take 2 weeks to 4 months before you ever actually get a medical death certificate that would say ultimately suicide, to where then you could actually go and outreach to the community or the family towards providing resources. So that's a piece we're really trying to work towards in the future, is how do we learn about suicides sooner rather than later, so that the resources that the department has could really get to the people that need them most. Okay, that's it. Thank you so much.
So, Heather, gave you some of the definitions that I was going to talk about, I think, which is probably going to be helpful. But first, I just want to say it holds some special significance for me to be talking to the Alumni Association. I found out for years and years I wasn't getting the newsletter, and I found out that they had me listed as deceased. So I'm hoping that wasn't an editorial comment on someone from the Alumni Association having heard me talk before. So just in case, I'm giving you warning. As Nancy mentioned, my job is Director of Children and Family Services at Riverside Community Care. And I spend about half my time doing that, and the other half of my time I'm working on basically trauma response in the community and suicide postvention, which Heather mentioned, which I'll talk to you about in a minute. And this is something that I think we just there were a couple of us at Riverside that just kind of accidentally ended up, doing this kind of work. We were actually setting up a support program within Riverside, trying to help some of our programs that had critical incidents, where staff were, in those few occasions where staff had been assaulted or consumers had made a very serious and perhaps gory suicide attempt, and we were trying to respond to the staff and support them. And really kind of out of that, we started to do more of it. We would get calls and we would do more of it in the community, and gradually, thanks to Heather and her colleagues at DPH, we were able to get funding for it from the Department of Public Health and also from the Department of Mental Health. So we're actually right now in the midst of building a statewide response system, and we've actually trained well over 100 people now throughout the state in central Massachusetts, out in western Massachusetts and Springfield. We've been training people. We've got people trained, all around the metro suburban area in Boston. So I think we want to, really are trying to find a uniform way to, to respond to critical incidents. And I think one of the things that I've become a little bit more involved in has been postvention effort. And Betty was talking about what she didn't learn in social work school and what sounds like is going on now. So, suicide assessment certainly was not something that most of us got any training with unless it was in our field placement. And certainly I don't know when the first time I heard the term postvention was, but it's only been a handful of years, I'm sure, that I've heard that term, and now it's really something that I'm quite immersed in. And basically, when we talk about postvention, just to give you sort of the working definition that we use, it really is providing immediate mental health services in the aftermath of a critical incident or a tragic loss. And basically, I think we can do a number of things when we're talking about postvention. We think we can reduce the possibility of contagion, because when you're talking about, for high school, for example, if there's been a fairly public suicide, there's some studies that show that the risk of contagion is maybe 1 to 5%. So those are some kids that we want to make sure that we get to as quickly as we can, and we want to do that. We want to help stabilize the school setting and have people find a way, the appropriate time, and people always wonder what's the appropriate time to be able to get back into their regular routines at school. So we really want to help them do that. And also we want to try to help people really sort of facilitate some kind of place where they can do a healthy grieving, whether it's in the school or whether it's in the community. And I think it's been, we talk about research. I mean, there's very, very little research that's been done on these issues. But, anecdotally, it seems like it does, it does help. We have a number of examples, that we feel like we've really been able to make inroads and help schools and help communities, too. Sometimes we go in with postvention efforts in communities when there's been a very public suicide in the community, and do the same kind of thing. And really, you talk about gatekeepers. I mean, the people that are out there, the counselors, the school teachers. We actually do a lot of work with clergy. We're actually training a lot of clergy in critical incident response and postvention, really trying to help them, deal with these things that we weren't trained for, and they certainly were not trained for. So those are some of the things that we do. And I think if there's 4 things that I would sort of want you to sort of get from, my my few words here tonight would be, first that postvention is suicide prevention. We really see it as suicide prevention. I think number 2 is that, especially with adolescents, we really do see a huge increase in risk-taking behavior after there's been a suicide in the school. And I'm going to tell you a little bit about that. I'll give you an example of that in a minute. Third, the impact of these deaths is, I've been doing this for, at least 7 years now on a fairly consistent basis, and the impact is far greater, I think, than we ever can imagine. Just to give you a very brief example, I teach at another school, and I was talking to my students one time about, a bus accident that I had, in a middle school that I had been very closely involved with, the postvention services after the accident. And, it was a school of about 800 kids. And during that time, there were 44 kids on the bus. There were 4 students who died. And we felt like, we provided services over the course of a year. We provided services to in excess of 150 kids. And I was sort of talking about this, and this student came up to me after class. And this is now 7 years ago. And she said, I was in that school at the time, and I dropped out of school. She knew one of the girls, who was killed, and she ended up dropping out of school. She was not a kid that anyone ever identified. I knew all those kids, their names. She was not a kid that we had ever identified, and here it is 7 years later, and it really, is sort of still a very powerful, time for her and memory for her. So that just sort of gives you an example. And we always, when we sort of talk about critical incident response, we're always talking about, the circle of risk, really trying to identify, kids who are right in the immediate circle, who might have actually, if there was a car crash, who might have actually been in the car. The next concentric circle would be their, maybe girlfriends and boyfriends, family members, going out, just keep going out. It could be ex-girlfriends, ex-boyfriends. It could be other students in the school who have lost a parent recently, or their parents got divorced and they're pretty shaky, and so we want to make sure that we're checking in with them. And in the course of doing that, our experience has been that probably we tend to identify, routinely 5 to 10% of kids in a school that really that are kids that we want to check in with and make sure that they're doing okay. We want to have somebody follow up on them and make sure, that they're doing okay. So the impact is great. And the fourth thing I would really like to say about this whole field, this new development, it's a very new, exciting, I think, developing field. There's a lot more that we don't know than what we know right now. Is a lot of this stuff, especially with critical incident response, is sort of historically been tied to debriefing, and then there was a whole phase. Those of you that that know about this sort of critical incident field, know that sort of for a long time debriefing was considered to be taboo, and it was sort of thrown out. And there were a lot of things that people have gone back and sort of changed. Kind of the way that they look at things, the way they handle these kind of situations now. Now we really don't want people necessarily to tell their story to other people. That's sort of intuitively, what we learn in school. What do? We talk about feelings, and we sort of tell our story. And a lot of times, that's not what we want to happen. And we definitely don't want people to hear other people's stories. and have their memories become contaminated. So those are the kinds of things that we're trying to do now. It's always voluntary now, and also it's not just one time. We really want to follow up with people on these kind of situations. If anybody is interested in learning more about this, we do a number of trainings on it, and we're actually doing an all-day training next Wednesday out at Regis. That if you're interested in psychological first aid, please feel free to come. It's very cheap, and if it's something that you think you might want to learn more about, I think you'd find it a really interesting training. Just quickly, I want to tell you just sort of how does this translate into into what happens out in the field. And I think that I want to tell you a little bit about my work with the Needham Suicide Prevention Coalition. A couple years ago, within a period of 18 months, four teenagers in Needham killed themselves. And they were most of them were very public. And they were very shocking to community people because there were some of the students had been, extremely well-liked, extremely popular. There was a lot of, concern, early on that the community was, burying its head in the sand, and a lot of blaming that was going on, which very often happens around suicide issues. There's just the blaming is rampant. And after the fourth suicide, that really was for the adults in the community, in the school faculty. It really was the tipping point. And people really mobilized at that point and developed this, grassroots coalition. About 35 people, everybody from, it was both school and community, which I think I know actually, inadvertently have learned a lot about coalitions now. And, one of the things that's really important is that it be both school and community-based, and that's been it's been very effective. We have representatives from who are selectmen and school officials and parents and kids and clergy and just a whole host of people on this, trying to figure out how do we reduce the risk factors in the town, and how do we enhance the protective factors against suicide. So this is what we've been doing. Now, my piece in this coalition, because I'm a clinician, and because, unfortunately they didn't have joint degree programs when I was here. I'm very envious of everyone that gets a chance to have a combined MSW, MPH degree now. But this was new. This was very new territory to me. But really, I think my work has been primarily in the clinical realm. Around postvention, and really one of the things that we did, there's a huge piece of this is case finding, because what we know about adolescent suicide is about 90% of these kids, you see different figures. I've seen 85 to 95, but about 90% of these kids, have depression, some other kind of mental illness, substance abuse, or both. They're dually diagnosed. They're GLBT kids, or they've been bullied, or they're bullies. Those are about 90% of the kids. So we really sort of set out to really find as many kids as we could, and make sure that they were doing okay, that they were getting services, and it's been quite an experience. So we've done that. I mean, there was the first year we identified about 35 to 40 kids that we actually referred on for follow-up mental health services, for longer-term mental health services. We have a psychologist who's at the school 2 days a week. This year we've added somebody. Catherine is at the middle school 1 day a week. Again, we're really sort of there visibly. Looking for kids that are at risk, because we know that they're there. When you look at, those of you that are familiar with the youth risk behavior surveys in the high schools, know that there's always a percentage of kids, who have been contemplating suicide. Depending on the school district, it may be, 8 to 18% of kids have contemplated suicide. And there's, usually a percentage, usually around, 3 to 6 or whatever that have actually, made a suicide attempt. So we want to make sure that that those kids have access to services. That's one of the main protective factors. So we've been doing that. We did longer-term groups. Again, Catherine did one of those, but we did groups for 80 kids who had been connected to the kids that had killed themselves. And, from 8, I think the groups ran from like 6 to 12 weeks. There were varying degrees. A lot of the kids, we put them through a rope course before they started the groups, just to sort of get them going and facilitate some cohesion and discussion. I actually did a parent group. I had a parent who contacted me who was very concerned about her son and her son's friends, and she had been talking, the mothers had been talking, and they had been good friends, very, very good friends, with one of the students who had killed himself. And they really got, these kids were very much out of control. I mean, they were just getting, drunk all the time. They were engaging in a lot of risky behaviors, and so we found ways to reach out to the kids, and also, I spent considerable amount of time working with the parents. So we're doing those kinds of things, and then the much more public health kinds of things. We've done the SOS training for the kids in the middle schools and high schools around suicide prevention. Trying to get, the big thing with kids is trying to get them to to basically say, if a friend tells them that they're thinking about hurting themselves, that they will go to a responsible adult. That really is, I think, for me, the essence of the program. That we can get kids to start doing that, and in some cases, it's worked out very well. We do the QPR training throughout Needham. A lot of people in Needham are very involved with QPR training. Not only have we trained ministers and business leaders and all the town selectmen and all the school, the school committee members. We've also trained the members, all the women, the Women League of Voters. We trained all of them. We're sort of basically saying that we think everybody in Needham is a gatekeeper. That's sort of the way we're approaching it, and just sort of getting it out and trying to. The coalition works very, very hard to basically try to reduce the stigma of suicide, and not have it be a problem that's been swept under the rug. So that's sort of in essence what we've done. Just very quickly, our next goal, or what we've already started working on, which has been extremely difficult, is adolescents don't have the highest rate of suicide. Heather was talking about the middle-aged men and elderly. We're trying to go off after those populations and make sure that we do the same kind of case finding there. And the elderly, we're doing the coalition's doing a fairly good job. It's been extremely difficult to get to the middle-aged men. We're doing a little bit more of it, but it's been a hard population to reach, has been our experience so far. So the other thing I wanted to just I did want to plug, if this is an area that interests you, Heather was talking about the mass suicide Coalition conference on May 14th and 15th. We're actually doing a panel on the Needham, specifically on the Needham Coalition, and then Larry Berkowitz and I are doing a panel. Basically, I think it's an hour and 45 minutes on postvention issues, specifically in high schools. And if that's something you want to learn more about, we're actually going to sort of walk people through the steps and talk about what works and those kinds of things. Because the same questions always come up every time we go into a school. So if you're in the school business, I think I would urge you to think about coming. And it's very inexpensive. I think it's $60 for 2 days, and get a lot of CEUs. So that's it. Thank you.
So we have about a half hour for questions. Feel free to jump in.
I was just curious what, if any, outreach has been done to like media outlets in terms of both the contagion factor as well as just how to treat incidents sensitively and/or in a way that could be more preventive.
Media, have you done outreach to them?
Yeah,
yes.
in a coordinated way.
Yeah, actually, there are, the media is a huge issue, because I think sometimes what they've done is they've actually, they actually sort of put, every single detail of a suicide, how it happened. And we definitely don't want them to do that. And, I think the other thing that they do too is sometimes they really sort of glorify students, and so everything you read is, very much just what, just absolutely what a wonderful person this kid was, and there's pictures of him in his, all-star sports uniform, and so we're really concerned about those kinds of things. And the schools across the board, their inclination is to stonewall the media, and that doesn't work either. Because then they just go out and they go out and they talk to students instead of coming and talking to someone designated in the school department. We always want the schools to have a public information officer. So, we get them to do that, and we really try to talk to them a lot. And there are guidelines from the Columbia School of Journalism that they're called the Annenberg Center, and they have extensive guidelines on how the media should cover suicides. And they're very good guidelines. And we actually, the Needham Coalition actually has a website. It's called needhamacts.org. And we've put the media guidelines on the website. So we asked them to do that. I've been through this, actually. I've had conversations in the past with the Globe around this issue. And even the Globe, which is such a, venerable newspaper, and they even really weren't sure about how to cover suicides themselves. So I've had conversations with an associate editor at the Globe about this very topic. But yeah, I think we want to make sure that as much as possible we get schools and the media to have dialogue. We want them to we want the school to at least have a press conference, at least, or not a press conference, but at least talk to them at least once a day.
There is there's one study out of Europe. You may be familiar with it. I think it's the net. Oh, okay. It's a Dutch study, I believe, in which the national, is it Austria? Is it
trains?
Yeah, where they did a
trains.
whole national sort of they really viewed the media as the target population to do the intervention on, because they felt the media was having such a pernicious effect on suicide, and they had quite good responses and results from targeting the whole national media. So I do think that there's probably Needham and beyond a role for us as educators and as social workers around beginning to understand the power of electronic media for shaping this, and also for us to shape them, right?
Twofold question, dealing with basically with suicide in the elderly. For Betty, I'm wondering, on campus with the current project, is that connected at all with the VU Institute for Geriatric Studies in terms of just looking into it with on-campus resources? And then also for public health, I'd like to hear a little bit from the Department of Public Health about how much of their efforts are specifically geared towards elder suicide.
Well, yes, it is connected, and in fact, IGSW, when we created the fellowships, there were 5 of them. We held one for an IGSW fellow, and we have someone, Reeve Goldhaber, who is working with us and also works with IGSW and actually runs a fabulous program here at BU that some of you may have been involved with, the Geriatric Enrichment Project. And this model of training actually allows students to move from setting to setting, working in with geriatric populations in both macro and clinical settings. It's actually wonderful. And Reeve is busy doing quite a bit of resource development for both IGSW and GEM. IGSW also has independently on their own taken this on as an issue. They've created some courses, and they also did submit recently for one of your community-based partnering grants. So yes, the connections are there, and they're going to, I hope, enhance and continue.
Do you need a dollar number? Like, how many dollars?
No,
I don't know that.
I'm just curious, because I mean, obviously, there's been a lot of focus on youth, but also with the elderly, I mean, it is just such a huge issue.
High rate. Yeah, I mean, I would say, I don't know if this is going to answer your question, and I can certainly follow up with you afterwards. Maybe if you can leave me your information, I can get you more information. But there currently is an RFR that's being reviewed, so it's already passed. You can't apply for it any longer. But it's a community prevention grant. It's a continuation of a set of grants that are ending a 2 or 3 year period. And of the applications that are being reviewed, I think there's 21 of them, and maybe 75% of them, so of that, maybe 17 of them are specifically targeting the elderly in one way or another, either through gatekeepers or specifically working with seniors in their homes or in their community settings. So that appropriation in the end will be pretty significant because it is over 3 years. This year, which is only 3 months left because the fiscal year ends at the end of June, but then we'll continue for 2 more years. So we hope to fund 5 of the total 21, but be able to fund at least 5, perhaps even more than that. So that's public information as well. So once it comes out, you can just look on the website to find out who's been funded and how the resources have been allocated. But before you leave, if you give me your name and number, I can get you more detailed information.
Mr. McCauley, you had said that you try to prevent people's story from getting out after suicide, from them sharing their stories, and so I was a little curious about that. And like, first, what happens when it does, and then if you try to prevent that from happening, and how you do that?
Yeah, I mean, that's more of an issue with, I think, with a critical incident. But yeah, we don't want people to, if we can help it, we don't want people to be talking about, the gory details. Because, I think we know now about vicarious trauma, right? And I mean, if you hear these stories over and over again, especially if you're younger and very impressionable, then they can become your story. So we try to prevent that. It's very hard when you're talking with adolescents to be able to do that. But when we can, we do. And, and try to sort of identify who had the exact same experience. And if we're going to do a group with them, some kind of a coping group or what we call a guided conversation, what we do is we try to, group those people that have had the very same experience. So.
Yeah, I just want to say also that there's been a whole kind of struggle. Jim, you alluded to it, and I think I just want to say there's been a whole struggle in the field about a particular form of critical incident stress debriefing that was used in the wake of 9/11, about which quite a substantial amount of research was done, and the findings were actually suggestive that the interventions made people worse. They relied a lot on immediate press to tell the story. What are you feeling? What are you thinking? What happened to you? A lot of pushing people to articulate. And as our skills of trauma intervention develop, we start to understand that these things happen in their own times, that people don't necessarily need to be pushed to tell their stories, and some people need to quiet down and go away and seal over, and we need not to be in there mucking around when they need to be being quiet. So I think a piece of the struggle around the terminology, almost the use of the term critical incident stress debriefing is sort of loaded now, and there's a question. If some of you have been trained by the American Red Cross, you'll know that for a while they were teaching it, and then they stopped teaching it, and now they don't talk about it, but they used to talk about it. So that, like, it's kind of we're sort of, our research on trauma intervention is just galloping in a phenomenal way. It's actually kind of hard to stay current with it. But I think this idea that, of course, people have to tell their stories, But what happens when they tell their stories and with whom they tell their stories, under what circumstances they tell their stories, and then who does what with their stories and in what time framework is really the issue for the field right now, and that we're working with. And that mindfulness is really, really welcome. It signals a sense that, I think for all of us, that the research findings about not pushing people are really getting integrated into practice environments.
Can I just add to that? That's, I mean, what we do when we go out, usually a lot of times if it's up to us, we go out later. You know, I think sometimes if there's been a critical incident, they want us to come out the next day. And sometimes we'll go out and we'll talk to, school administrators, but we really sort of, if we can help it, I think we like to wait, and really see who's struggling with it after a while. And we really try to help people identify what their strengths are. We call them, we call what we do coping groups, because we really sort of say to them, look, when you've had past, awful experiences, what has worked for you? What's been helpful? Is it helpful, is it helpful to sort of go for a jog? Do you like to exercise? Do you like spending time with your friends? I mean, is that helpful to you when you're under a lot of stress? We really try to help people identify those kinds of things. We really encourage people to drink water, because we know that adrenaline stays in people's system after an event for at least 72 hours, so we want them to sort of flush out their systems. Do a lot of psychoeducation, and if we can, we try to slow them down on the storytelling, definitely. And we also talk about reactions. We don't want people to just sort of talk about feelings. We want people to sort of monitor how their body's doing and how they're doing cognitively, behaviorally. Are they tending to withdraw? So it's not just about feelings. So.
Yeah, I had a question on the metrics around the attempted suicide or people harming themselves. Are hospitals required to report statistics when clients present who they have on suicide watch? Does that enter into the database? Because
Say, what do you mean?
Well, so
Wait.
a client presents to an emergency room, and the emergency room determines that they are
I
at
see.
risk of committing suicide.
So then your question is?
So does that data enter into attempted?
No.
It doesn't?
No. No, at least not from what I understand. Do you understand that a little bit better?
I think it depends on the surveillance and reporting mechanisms in a.
Because I think it would be written in a narrative,
Yes.
of which, for the Department of Public Health, we collect the numbers. We don't collect the narratives. So if it was, but I wouldn't be the expert on this at all,
Susan Gallagher.
but that's my thought.
But you understand like where I'm going with that, because then there are many
Right.
cases of people who are at
Leave,
risk.
right.
Who are at risk. And those people can often fall through the cracks.
Sure.
The other question I had was on health education in the state of Massachusetts for high school students. Is this SOS program part of health education curriculum so that all high school students?
No, it
No.
can be.
It could be.
Yeah.
I mean, in other words, like we talk about stroke prevention, what to do when you're having a heart attack, and all of the people that might be involved. If I think I'm having a stroke, it's the same thing with suicides. All of us, in a sense, have to be those gatekeepers. I mean, in the public health community, that would be the argument, correct? That would be the ideal. Because now they're talking about stroke that same way.
But I'll tell you, just my experience with school systems has been, there's still the myth out there that if you talk about suicide, you'll give people the idea. Schools don't like to talk about it if they don't have to. So SOS, the curriculum is not, I think is probably not in
would say it's
only,
like a
a
minority
handful of school systems throughout Massachusetts.
There's also a lot of variability in health education from school system to school system, and who teaches it and what constitutes it is different from school to school. So, and remember when you were in, many of us, those of us who are over 40, remember, who taught your health ed? was the gym teacher, right? And a lot of times, you know, I don't know about you, but she wasn't too into it. We've gotten a lot more refined in doing that, but there is a lot of variability from system to system. So you should probably assume that most people in high school are not getting a lot of good suicide education.
I worked with the kids from South Boston, and we had a Charles River Hospital had a unit where we had a lot of those kids. And I always wondered what happened because I thought that we were pretty successful. And what was wonderful is the community was so involved that when a kid was discharged from the hospital, they would get a paid job in the cemetery. There would be all kinds of activities that they could go in. It really tried to do something about improving the lives of kids in that community. And I don't know what happened since. Maybe you know something about it.
Yeah, well, do you know about it?
No, I don't.
Oh.
Thank you,
South
Joe.
Boston Collaborative.
Yeah, just, you know, I think Robert Macy, who's one of our primary instructors for our trainings around trauma, was one of the primary people involved with that, and, you know, it was...
Just for the group, I don't know, there might be people who are transplanted from the area.
Oh,
who don't know
okay.
what happened in South Boston, so-
Well, do you remember what the years were?
It was in the
Early-
'80s to the '90s.
Early
There were
90s.
there were 7 kids that committed suicide.
Yeah, at least 7. I thought maybe there were,
In
I
one
think,
particular time.
yeah, I
Middle of a
think,
heroin epidemic.
yeah,
Right, yes.
yeah, just an extensive epidemic of, suicide among young people in South Boston, during the, 80s and I think early 90s. And, they really sort of, I think with a lot of, help from the Department of Mental Health and Department of Public Health and the city, did extensive amount of, case finding and education around it. And I think they identified and basically got into, some kind of follow-up services, over 800 kids.
Oh,
Yeah, it was a huge effort.
we also saw families, they had families that came in
Yeah.
almost every night.
Yeah,
I met
yeah.
with the psychiatrist.
Yeah, it was really an unbelievable effort.
Did they solve some of the problems? Because some of the problems causing suicide were really endemic to that particular community. And
Yeah.
I had just wondered if what is going on, if it's still.
I think they made, there's a lot more services that are there now, I think, in the schools and the South Boston Collaborative, and, I'm not sure, what the, I'm not sure about recent suicide issues in South Boston.
It's a different kind of community. All the gentrification, it's a different kind of community than it was in the 80s.
Yeah, yeah.
Yeah, that's true.
Yeah.
Other questions? Yeah.
I have a question for you, Betty.
Yes, ma'am.
I'm curious your thoughts about why there has been so little research and why there continues to be resistance to having more training, especially in social work schools.
Well, I have a lot of thoughts on it. I think I'll know more in about 6 months when we get this data analyzed and also after we talk to faculty. But I think that social work education compacts a lot of stuff into 2 years. And there's more stuff to know. We're getting smarter and we're doing more work and we're starting to understand the human condition. And it's hard to fit it all into 2 years. So that's one piece, is that there's more to know. I think the second piece of what's going on is that there is what I would call a disconnect, although that's probably too strong a word. There's a thinning of the relationship between social work educators and social work practitioners. In the practice community in particular, in the education community, there are fewer people who have practiced for any length of time. More and more you make a choice after your MSW education about whether you're going to go in the practice direction or whether you're going to jump on to doctoral education. And so we have some great new faculty members. Many of them have good practice backgrounds, but it took a lot of work to find those folks. Many people have fewer than 2 years of practice education before they present themselves to us as faculty members to be hired. So I think a piece of it is the less time you spend in the community, the less you have unless you're paying really good attention, it's really easy to get lost in your own research and to not have a big expansive view of, oh my God, the way trauma wipes through, throughout a community, or the way particular methamphetamine wails through another community, or whether those issues. So that's another piece. Second piece is that I think, in general, suicide has only really emerged as a kind of come into its own as a focal area for study and intervention since the 80s. And many social workers, I think, and you all can testify to this, we worked or came of age in systems where if someone was suicidal, you passed the client to somebody else, right? Oh, I got to call the psychiatrist, right, and call them in. And there's been this change. We are now the dominant mental health profession in this country numerically. At any given day, 1.5 million Americans are in a healing relationship with a social worker of some type. That's 0.5% of our population is relating to a social worker. So I think in part the demand on the profession is greater to respond with these kinds of crisis intervention skills. And the curriculum hasn't kind of caught up to that yet. So those of us in academia are really struggling with this issue of what does it mean to renew one's curriculum. And so those are some of the pieces of it. The other piece, I think, is just that, you have a faculty, you have a profession that hasn't been trained in it, including your faculty. So of course they're going to be resistant. You're supposed to be the know-it-all faculty member who wants to be exposed for what you don't know. And so then it becomes our job, for those of us who are willing to expose our ignorance, and let me tell you, it's been very humbling, to really help each other to learn that stuff. And that's why we created the faculty fellowship program, so that faculty would be able to find a place where they could learn with one another and admit, I don't know anything about this. And we had many, many faculty members tell us, the last time I was taught anything in suicide, it was back in 1978, and I learned about modes and means and methods, and that's all I know. So I think the resistance is the jammed up curriculum and the pressure of many issues. We also have to teach about HIV/AIDS. We got to teach about violence. We got to teach about neuroscience. We need to teach about psychopharmacology. We need to teach about public health so that people have the basic prevention tools when they go out there. And that's a lot to pack in on top of social welfare policy and HB and so we're working on it.
Thank you.
We're leaning so we can pack in more to our wonderful students' brains, right? Our own brains. Well, you want to say the question?
Well, I just thought Betty speaks so well to this, and she didn't even mention it, which I'm so shocked at. But suicide, I think, or
the issue of the way we view it clinically, exclusively clinically.
I
I actually think that is an important point. I think that for the most part in social work, people don't think about levels of prevention. For those of us in public health, I know you're laughing at me because here she goes again with the levels of prevention. For those of us in public health, we really are interested in how do you create a community in which nobody wants to take their lives, okay? That's how far back we want to step. How do you create, what Martin Luther King called that beloved community where people want to stay alive with each other? In mental health, and in particular in pathology-driven mental health paradigms, which is what we're all getting paid under right now because that's how the reimbursement mechanisms are driving it. You gotta be using primarily an intervention lens. You're only intervening after somebody's basically got the knife to their wrist and the gun to their head. And most social workers, when you say suicide prevention, think about exactly that. They think, okay, I'm going to talk the person who's suicidal out of being suicidal, or I'm going to do something, I'm going to contract with them, or whatever the intervention is that they imagine will work at that moment of suicidality. And I think in general what we want to do is sort of crack open this preoccupation with that level of intervention, what we would call in public health tertiary intervention, and really back it up and do what Jim is talking about when he says case finding. We're talking about secondary intervention. That's the early intervention stuff where you're looking around for those people who raise the flags. But even more so, how do we begin to create trauma prevention? Because one of the things that we know that leads to suicidality is growing up in repeated exposures to traumas, or substance abuse prevention, or violence prevention, because those are the things that create the kinds of circumstances that make people feel like they don't want to stay and hang in there with the human condition. So again, I think it is because social work hangs out for most of the time doing tertiary intervention. We like to think of ourselves as the people who are willing to pull up our sleeves, jump into the water, we'll get those people out of the water. Public health people hang out upstream, and they actually even will use that term. We're in upstream intervention, and we like to look at how is it that we don't end up there, that's fewer of our people. What are the protective factors that we can enhance and potentiate so that people don't land in the water, so that you all don't have to go into the water and get them out. That is a hard switch for social work to make. I can't tell you. I mean, I've been doing this public health social work thing for 20 years, and I have to say, it makes me thrilled to hear Jim talk about case finding, because that's good old public health social work. This is really, we really have to be about the business now of learning the skills of prevention, because eventually, not too long from now, we are going to have some kind of national or universal health care. It's not like I got an inside line, but Hubie told me. Hubie Jones told me. No, the other night he said so. I heard it. No, but we are going to have this, and at that moment, suddenly prevention's going to be golden. Suddenly, this pathology-driven model is going to become a lot less interesting and a lot less preoccupying, and social work is really uniquely placed to be able to take advantage of that, and if we train ourselves appropriately, and if we begin to make ourselves into prevention as well as interveners, so preventers as well as interveners. So I invite you to come to join us in the new Public Health Social Work Training Institute. We know that everybody can't go out and buy an MPH. We know that there's a lot of people who cycled through the system either before we had a public health social work dual degree program, or who came to understand that, boy, they really did like public health. They want to be about the creation of that primary prevention. And so we do have, through professional education now, it's just launched, thanks to the generosity of one of our donors, a Public Health Social Work Training Institute. We're teaching this whole thing on how do you link prevention and intervention? How do you get, okay, so you didn't go to public health school, but how do you learn to make some of those skills your own? So I hope you will pay attention to that and join us for it. It will be a couple-year-long initiative. Thanks.
So it's 8:30, and just in recognition of the fact that maybe some of you want to speak with some of our panelists afterwards, we should probably wrap here. So if you join me in a round of applause thanking our fabulous panel. And I think I realized in my own haste to hurry through their introduction of their titles, I forgot to introduce myself. I'm Nancy Ginty Butler, president of the VU School of Social Work Alumni Association, and this is one of the many events that we put on throughout the year to bring alumni back to the school, talk about making connections between professors and social workers out in the field, but this is also our way of coming back and remembering our time here. So if you're interested in any other things the Alumni Association is doing, I would encourage you to contact the school and get involved, because there's lots of opportunities. So thanks for coming.